start. We've figured it out. This is Jess Kimball. She's going to be our guest speaker, talking about various different issues relating to postpartum and midwifery and doula care. So I will let her get started.
Hi everyone. That was like 30 minutes of tech difficulties, so I'm trying to settle in. But my name is Jess Kimball. I am a birth and postpartum doula. I primarily work with families during the postpartum period, specifically with overnight care and care centered around perinatal mental health support. So I'm going to be talking about a bunch of different things, but they will all come together in some kind of way at the end. I try to use gender-inclusive terminology when I talk about the families that I support, but sometimes I'm quoting research, so just to note that if I'm saying father, mother, woman, I'm usually talking about research that I'm quoting and not necessarily a family that I've supported. I try to use parent and birthing person so that everybody feels included when I'm talking about care. So I'm going to start by talking about perinatal mood and anxiety disorders. I think that this is something that providers need a lot more education on. I think that when we provide care to families, and I'm not saying this is the fault of nurses because it's just the model of care that we have, but a lot of times people go out into the community and that's kind of where they're in this period of time where they need a lot of support. And the only support they're getting is a very quick appointment postpartum. Perinatal mood and anxiety disorders, often called PMADs, is a term used to describe the distressing feelings that occur during pregnancy and throughout the first year after pregnancy. They are often diagnosed in that first year after pregnancy, but they can be diagnosed much later. The way that we determine if it's a perinatal mood and anxiety disorder is when the feelings started. So somebody could be experiencing postpartum depression and have a 2 or 3 year old, but we look at when those feelings actually began. And this is different from the baby blues. The baby blues are the mood swings and feelings that come 2 to 3 weeks after giving birth. They usually don't last more than 2 weeks. They're just a few hours during the day, not the same thing as depression, but still extremely common and something that people should be aware of. PMADs are on the rise, and I'll get into that a little bit more, but I think you all know the way that the world has changed with COVID and isolation. Mental health is a huge concern for a lot of people. There's a long list of symptoms, but they're very similar to the symptoms that someone experiences with any type of mental health situation. But as we get into each different type of perinatal mood and anxiety disorder, there's very specific things to be aware of in the way that people talk about themselves and the baby that they gave birth to. So like I previously mentioned, the timeline of the symptoms and how long they're lasting is the main way that we can kind of tell if it's postpartum depression or the baby blues. With the baby blues, there's irritability, fatigue, and sadness, but with postpartum depression, it's a lot more severe. There's aggression, extreme stress, and a lot of feeling of detachment from the baby on a different level. Like somebody who is experiencing the baby blues might be like, I thought I was going to just immediately love my baby because I carried this baby, but I don't really feel that and I'm struggling with that, and there's just so many changes, while somebody who's experiencing postpartum depression may want to completely detach and not be involved in the care of the baby. And like I said before, it can be diagnosed 1 to 2 years postpartum. But it's not just depression. I think there's a huge focus on postpartum depression. In my work as a doula, oftentimes I tell people I work with families during the postpartum period, and people associate the word postpartum with depression. They think I only work with families who have postpartum depression, and that's not the case. I think that as we start to talk about the postpartum period more, people are understanding what postpartum actually means, and that it's not a diagnosis, it's a period of time. And as they separate the two, there is more talk about postpartum depression, but it's not just postpartum depression. It's also perinatal mood, perinatal or postpartum anxiety disorder, which impacts about 10% of people. We're seeing these rates rise a lot because of situations in communities, but also I think that as we start to push for more screening and as these things are discussed more and providers are better educated on the topic, people build more trust with their provider and they're more willing to disclose this kind of information about the thoughts they're having. There still is a lot of fear for families. If they disclose this information, is their baby going to be taken from them? That sort of thing. But as people become more educated and more screening is done and resources are put in place, I think that we see the rates of PMADs increase just because there's more disclosure about what they're experiencing. There's also perinatal psychosis. This is a much more rare occurrence, but again, it's something we're hearing a lot more people talk about. One of the key differences between postpartum psychosis and postpartum OCD, I think people stereotype OCD a lot and they think it's someone who's just is very like particular, type A. They want to keep their house looking a certain way and they're very like nitpicky and have that like more intense anxiety. But OCD actually includes a lot of intrusive thoughts. So somebody that I work with who has OCD might say, I'm really scared that I'm going to get in a car accident and it's going to kill the baby. While someone with postpartum psychosis is more likely to say something like, I feel like I need to drop my baby. Something is telling me I'm supposed to drop my baby. So like with OCD, it's more of like a fear. I'm scared if I walk down the stairs, I might slip and I might drop my baby. While someone with psychosis kind of has these thoughts occurring that are telling them to do that thing. OCD is more anxiety, and it prevents a lot of people from, I think, accessing resources because that intrusive thought of I'm scared if I get in my car with my baby, I'm going to get in a car accident and I'll be fine, but something awful is going to happen to my baby. They're not going to want to drive to an appointment. They're not going to want to go to community support groups. That anxiety is going to increase and really prevent them from living their life and accessing help, which is one of the reasons that screening early is extremely important so that we can catch those things and make sure a person doesn't end up in that place. And someone with postpartum psychosis is likely that they are going to need to be separated from their baby for a period of time, but it's not, we're taking your baby and you can't care for your baby. It's we need to get you the resources and help you need to be in a place where you can care for your baby. And that can look very different for each individual case of postpartum psychosis, because there's someone who, maybe is just in the early stages and can get support and care for their baby. And then there's people who are in a much worse place. It's been going on for a long period of time and they need a lot more help. So with depression and anxiety in pregnancy, we're seeing it in about 15 to 21% of pregnant women. About 21% of women experience major or minor depression postpartum. Perinatal panic disorder is an anxiety, a form of anxiety that occurs in about 11%. OCD we're seeing in about 11% as well. PTSD we're seeing in about 9%. Bipolar in about we're seeing about 70% of women with bipolar stopping medication, who stop medication while pregnant, relapsing, and becoming their mental health becoming a big concern in pregnancy leading into postpartum. And then postpartum psychosis is about 1 to 2 in every 1,000 deliveries. There's a 5% suicide rate and 4% infanticide. People who have a history of mental health concerns, people who have bipolar, and people who have a family history of psychosis are the most likely to experience postpartum psychosis. And it does impact the baby, not just, it impacts the entire family. It's going to impact, if we're looking at the nuclear family, it's going to impact the mother who is, in this research who we're talking about struggling with a perinatal mood or anxiety disorder. But it's also going to impact their partner, and it's going to have an effect on the baby. We might see premature birth, a risk of SIDS, and a need for neurodevelopmental or neurobehavioral support. The engagement level that they have with their newborn is very different. So that newborn, we might see, based off of this, if they're smiling less, if they're not talking as much to their baby, how is that baby going to learn language compared to a baby who has a parent who's speaking to them frequently? And then older children are impacted as well because of the loss of attention, which is already happening when a new baby is brought into a family. But if they are, if one of the parents is really detaching from the family and distancing themselves, it's going to have an impact on the other children. I think it's also important to point out that it's not just moms and it's not just people who gave birth, but we're seeing if a birthing parent, if a mother has postpartum depression, the father is likely to experience it as well. They're more likely, but there are cases where they're experiencing it even if the mother is completely fine. I remember in the news, like a few years ago, people were talking about paternal mental health concerns postpartum, and a lot of women got really angry and said, well, like, you're not postpartum, how can you be experiencing this? But they are. Postpartum is a period of time, and they're impacted by that period of time as well. And African American women have a higher risk of developing perinatal depression. I think that this is really important to point out because I think, the United States has the highest maternal mortality rate of any developed country, and it's 3 to 4 times higher for women of color. That fear, that anxiety that they're feeling throughout their entire pregnancy isn't just going to go away when they have the baby. And 4 out of 5 deaths that are labeled maternal mortality are happening in pregnancy and postpartum. It's not just during childbirth. So these people who are living with this fear, it's not just going to go away. They're going to have, their anxiety is going to be much more heightened than somebody who is white, just because of the way our medical system is and the research that we have. So I think that's something that's really important to be aware of. So like I said, isolation is a huge factor in mental health struggles. During the pandemic, a lot of my clients joke about like their pandemic baby, where that baby just is amazed going out to the grocery store now because they have never seen people. It's just like so exciting to them because they're not super social. I have this one client, her baby plays independently so well, and we always joke that it's because she's a pandemic baby. She had to play on her own. She doesn't know what it's like to interact with other babies. But part of that, maybe we get this really autonomous, independent baby, but we have this family that's completely isolated and on their own. And, maybe they were looking forward to that 6-week postpartum visit with their doctor because that's maybe the only interaction with someone outside of their household that they're going to have that week. But a lot of my clients, that 6-week appointment was pushed and canceled, and they said, how are you feeling? Let's just do a telehealth appointment. I don't think you even need to come in, which brings up a whole bunch of medical concerns, but also, they're completely isolated. We've all been, living in quarantine and social distancing. Another thing that plays a huge role in mental health concerns is social media. You scroll through Instagram, you see somebody who is showing the very best part of their life, and you think, well, why isn't my life like that? why is that person's baby sleeping through the night? Why is that baby like just a champ at breastfeeding while I'm over here struggling? And I feel so alone. So those feelings are coming up. In reality, we could be using social media to spread more awareness, to talk about what's normal. I think that education is huge. One of the main things I do with my clients is I'm providing them with educational support and just information and resources. I think that providers play a really key role in that, and having an education on perinatal mental health, infant sleep, whatever capacity you're working in. I think that there is going to be a time in your career where someone asks you a question, and I've seen people ask questions around infant care to their pediatrician, and the pediatrician goes, oh, I just let my baby cry it out. Okay, maybe that worked. But for a lot of people, they're not going to want to do that, and it's going to raise their level of stress, and they're just going to listen to their baby cry, and they're going to be extremely stressed about it. And then they're going to go to that pediatrician's office, and they're going to say, we tried cry it out, it didn't work. And there's this like guilt and shame that's sometimes passed on by providers of like, well, that's your fault. I did it and it worked. Why isn't it working for you? So really having an education around what's normal and being able to provide that information to families when they ask, in an appropriate way. If you're working in the labor and delivery floor, you're probably not going to have someone who's pulling you aside while they're in labor and they're like, so what do I do about infant sleep? But, maybe it comes up somewhere that you're working, and being able to provide actual good evidence-based resources is huge. And then a huge part of it is screening. I think that, we have these super quick appointments, and the system we use doesn't really work. I went to the ER like a few weeks ago because I had a stomach bug, and they just go, okay, so have you ever thought about harming yourself or others? Like, I don't know you, and why would I answer that question? I'm here for a stomach bug. Like, I just want to get an IV and Zofran and go home. I just don't want to be nauseous anymore. Like, and I don't know this person. There's no connection. They're not even looking at me while they're asking that question. Why would I ever be like, yeah, you know what? Random person I don't know, I have felt that way. Like, that's just not, it doesn't work. I heard somebody say in a training I took, usually when you greet a patient, you're going to say, how are you doing? A mom never answers how they're feeling. I just asked someone the other day how they're doing. They said, oh, potty training has been stressful. Having another baby is stressful. But we're through it. Like, we have this going on and this going on. And they're listing all the things they have going on in life instead of saying how they actually feel. So just circling back around to that question in appointments. I think there's a really good chance that some of you may end up being the one that's doing screening with a patient. Usually when I go to the doctors, it's a medical assistant who asks that question, or a nurse. It's not my doctor who's asking those questions. So being educated on screening and having some really good skills in your toolkit of how to actually ask those questions. Maybe they give you an update on how the baby's doing and how, sleep's going and what the struggles are, but kind of circle back around. How are you actually doing? How are you feeling? And making sure you have the resources and know of who to refer out to. I live in Vermont, and Vermont has a really great program in place right now called Support Delivered, where each family can be assigned a caseworker completely free of charge that will see them through the entire process of finding a therapist. And they keep a database of who doesn't have wait lists, who actually has availability, because I think so many people are like, oh yeah, you could really benefit from talk therapy. And then that person goes home and they make a couple phone calls, and they're very discouraged when each person they call says, I don't accept insurance and my wait list is 2 years long. Good luck. So knowing the resources in your community and who to actually refer out to, and what to do when someone screens positive for a perinatal mood or anxiety disorder. And education is a huge part of that too, because I think a lot of providers say, okay, you have depression. Do you want to go on antidepressants? And a lot of people don't want to go on antidepressants. It's just how it is. And a lot of things that are going on in the postpartum period are very situational, and they're external factors playing a huge role in what that person's feeling internally. So somebody who, says, I feel depressed and my infant's not sleeping, and I know that the lack of sleep is making it a lot worse. A provider might say, like, okay, we can try antidepressants. You can try Cry It Out with your baby. And those are the two things that I see so many people get recommended, and they don't want to do either of those things. Especially if they have the goal of breastfeeding, they might be really, really against going on any type of antidepressant. And there's the opportunity to educate them on, what their options are. But there's also the opportunity to provide them with really good resources on good sleep hygiene and what that looks like for an infant to improve their sleep gradually, and not leave them in this place where it's like, okay, you just have to let your baby cry. Because some people that might work. I'm not saying like my opinion on it, but for some people it just doesn't work. I don't think any sane person can just like listen to a baby cry for hours and be like, this is great. I love this sound. And a huge part of that community support, I think, is doulas. I, like I said, primarily work with families postpartum, but I'm trained in birth, abortion care, pregnancy loss, the whole full spectrum. So a doula is a trained professional who provides continuous physical, emotional, and informational support to their client before, during, and shortly after childbirth. We're still not seeing like too much research on doulas, because I think that for a while doulas were viewed as like this hippy-dippy home birth type of thing. And then more families started using them. But now if I tell someone I'm a doula, they think I only attend births. And I'm like, actually, I focus primarily on postpartum. So there are a lot of types of doulas. There's miscarriage doulas, abortion doulas, bereavement, death, birth, postpartum. So there's some people who work full spectrum, so they support families during the fertility, birth, postpartum kind of period, but only things centered around that. So they might call themselves a bereavement doula, but they're really working with families, or a death doula, but they're really working with families who have a baby that is diagnosed as terminally ill, and they know that that's coming, and they support families through that. But there are death doulas who support all people through the process of death, and do kind of like care in combination with hospice care. Some of them help plan funerals and what they want that to look like, and just providing comfort and assistance in all that end of life brings. So the research is still kind of new, and we're seeing more be done. But what we're seeing is that there's fewer C-sections. Maternal outcomes are improved when a doula is present. They're more like, a person is more likely to have a spontaneous vaginal birth. They're less likely to use pain medication. They're less likely to have negative feelings about childbirth, which is really big for hospitals, because there's a lot of reasons why doulas can save a hospital money, but one of the reasons is people have very intense feelings and want to place blame when something doesn't go how they want it to. And people have very strong feelings about birth and the way they want it to go. And hospitals can face a lot of lawsuits around things that happen during childbirth. I've worked in a lot of different hospitals attending births for families, and I've seen providers do some things that people have very strong feelings about afterwards, and having a doula there. I have my own opinions on doulas advocating for families. I don't think that it is my job to speak for someone, but it's my job to educate my client and give them all of the resources so that they can make an informed decision. So I'm not going to be the person in the room that's speaking for my client, but letting them know as much as I can possibly let them know in an appropriate time. Obviously, there are emergencies where we need to be like, we don't have time to explain everything. We need to get you to the OR, a C-section is very necessary to save your life or the baby's life, or, you know, those things happen. But when it's an appropriate time to be able to provide my client with resources, they're going to have less harsh feelings about something not going the way they anticipated. And they're going to place less blame because they feel like they were able to make an informed decision. And then lower rates of PMADs, and then both mothers and babies are statistically more likely to have better outcomes. Some more research, we see a 31% decrease in Pitocin use, 28% decrease in risk of C-section, 12% increase in likelihood of spontaneous vaginal birth, 9% decrease in the use of medications for pain relief, 14% decrease in newborns being admitted to special care nursery, and 34% decrease in the risk of being dissatisfied with the birth experience, which also saves the hospital money. I guess not saves, it makes the hospital more money because people read reviews and they do the research. I'm in a couple Facebook groups for my community, and there are moms posting in there all the time about, you know, what was your experience at this hospital and trying to decide. They really want to choose a good hospital. So I think the decrease in the risk of being dissatisfied is huge for hospitals. I think that sometimes doulas kind of get this bad rep of, like, they come in and they take over and they want to go against what the hospital does. And I think that, you know, in any field, there are providers and practitioners who are not doing a good job. And just like, you know, some nurse that makes a mistake, you don't want that as like the label you get as a nurse. Like, that's what nurses do. No, that's not what nurses do. That's what that one nurse did. So with doulas, I think that there's a more positive way of looking at it. Doulas provide evidence-based information. So when educating a client, they should be providing information that supports what the providers want. If the provider is pushing something that isn't evidence-based, that should be questioned. You know, in the news, there were all these articles about the OB who wants to get to his golf game or whatever and pushes for a C-section. We should probably all be speaking out against that. You know, like, that, it shouldn't just be the doulas that are speaking up. Everyone should kind of be like, okay, why are we pushing someone to have a serious surgery that they don't need? Again, doulas save hospitals money. Birth is a $1 billion industry for hospitals. It makes them a lot of money. But I always think about the people who are most likely to get pushed to use a medication that maybe they didn't want to use initially, or have some intervention that makes the hospital more money. A lot of times the people that are being pushed to do that are lower income families who are not going to even be able to afford that hospital bill. And it's going to go to collections and it's going to destroy their credit, and the hospital might not even receive a payment from that family. So I kind of think about that, and I don't know, like, I haven't researched that and what actually happens, but I feel like that actually puts them at a risk of losing money if they're prescribing a bunch of medications and maybe people can't afford them. My own mom, I'm one of 7 kids, and she had my brother when she was 19, and she couldn't afford the hospital bill, and they just said, it's fine. She waited too long, and they were like, it's fine, we covered it. It's like, how much was that bill? Like $20,000? And they covered it? I feel like it's actually, there's ways that the hospital might be losing money, and by improving the outcomes, it can save them money, and then increasing the good reviews that the hospital is getting is going to make them more money over time. There's a lot of research on providing hands-on continuous support to people who are in labor. Nurses can't provide that. You know, maybe you get lucky and one day you're working and there's one person, like in Vermont, Gifford Hospital. I've heard a bunch of stories from clients where they said, I gave birth there and I was the only person there. It was great. Everyone just focused on me. That doesn't always happen. And if it does happen, there's probably other things as a nurse that you still need to get done. You're probably not in that room like doing counter pressure and like dancing it out with your client. Those are the things that a doula can do to help ease the pain and get them what they need. So I feel like looking at it as, you're all members of the care team. And a doula is another member who can come in and really kind of take some of the burden off of you. I like to talk about the midwife's model of care, not from like I think it would be great if everyone followed this, but realistically, every hospital isn't going to shift to this model of care overnight. And, but I think there's a lot that we can learn from it that goes along with those community support measures and the type of care that a doula provides. The midwife's model of care, the fundamental things that are going on that are really, really improving outcomes are that there's more prenatal and postpartum visits happening, which is more opportunity to catch something if something's wrong. And it's more opportunity to build trust between provider and patient because, as I mentioned earlier, someone is not going to disclose information to someone that they don't trust. And I think a lot of people already feel this kind of like power dynamic difference when they go into a room and they are the patient. I even see it with clients I've had who are doctors themselves. It's like as soon as they have a baby, as soon as they're the one going to an appointment, anything they learned, completely gone. And I've seen it with doulas and lactation consultants. Like I had someone tell me that they're a lactation consultant and they forgot everything they ever learned. Like they would go and they would work with the family while they were postpartum and they would give them amazing advice. They'd help them like with whatever they needed. That person went on to breastfeed. Great. When they sat down with their own baby, they were like, I don't remember any of it. And I think that can contribute to that kind of like power dynamic as people already feel like very lost and confused. So having trust with their provider, even if there is that power dynamic in place, still being able to trust them and really ask questions is really important. I think that this one depends on the location, but in a lot of other countries, midwives provide care to people throughout their lifetime. So when you decide maybe you want to go on birth control, you go to a midwife and they prescribe your birth control. If you need your pap smear, you go to a midwife and they do your pap smear. And a lot of them are starting to even provide care for men around reproductive health care and well body care. And even in like Vermont, I see a difference. There's practices who are like, yep, we do full spectrum care, everything. Some of them even do like IUI, intrauterine insemination for fertility because it's different from IVF. And they're able to do that, while some are like pregnancy, birth, postpartum. That's all we do. So it really differs depending on the practice, but midwives can provide care across the lifetime. And in a lot of other countries, only people who are high risk are going to OBGYNs. So there's been a few reports that have come out with research saying that 80 to about 83% of all maternal deaths, stillbirths, and newborn deaths could be averted if we switch to a midwifery model of care. And I say model of care because it's not just, okay, everybody go see a midwife. It's the model of care that really is leading to these improvements. I think a huge part of this is the training too. I think a midwife is really, I know someone who's a doctor and she originally wanted to focus on OBGYN as her specialty, and she decided not to do that because she said that the entire thing was extremely surgical. She thought she had experience working in acupuncture and doing all of these other things to put herself through med school, and she thought, she'd kind of do this private practice where she's doing acupuncture on people to help with their fertility and comfort in pregnancy and postpartum, and she's, you know, also able to like work at the hospital and deliver their baby. And she said that the entire thing was just C-section after C-section, and she realized she didn't want to be in surgery, so she switched specialties. But I think that midwives, the education they're getting really shows what a normal physiological birth looks like, and what that looks like in any space that they're birthing in. I think it's important for all providers to have that education, because the way we provide care in the U.S. is very like go to an OB, and if that's what we're going to do, then having that education for them, I think, is important. And again, like the why behind this produces better outcomes. It's more appointments, longer appointments, and the care just feels a lot more personal. And going back to the U.S. maternal mortality rate, we're seeing huge disparities by race for infant mortality, for maternal mortality. The rate of maternal mortality in the United States rose a lot during the pandemic. I don't know the exact percentage off of the top of my head, but I believe it's closer. I think the disparity is that we're seeing 5 to 6 times higher for Black women now. I think a huge part of this is during the pandemic, they wanted very few people in the hospital, so there was a huge push for inductions to, you know, if they're having a quiet day on labor and delivery, they might call people in for an induction to get them in and out of the hospital fast, and a lot of C-sections happening during the pandemic, and I can understand why they would think that's a good way to go with the risk of COVID, but it does have an impact on maternal mortality. And I think this can be really shocking for a lot of people to hear, but the reason why is institutional racism, and there's no like getting around that and saying that I don't think there's a way to say that it's something else. The father of modern gynecology, the way he developed forceps, the vacuum, all of these different interventions that we use during labor was by performing experimental surgeries on enslaved African American women. He believed that their skin was thicker and that they did not need to be sedated in any type of way, have any kind of anesthesia, because he believed that they could not feel pain the same way that white women do. He believed that white women had thin skin and that they were fragile and needed to be protected from pain, but that Black women could not experience pain. I think that when we educate ourselves on this, it's not like okay, he developed the forceps and the vacuum, we have to get rid of them, but understanding where they came from and the way that that's shaped the practices that have gone on. When gynecology and obstetrics and gynecology became really big in the United States, it pushed a lot of African American women who were midwives who delivered Black babies as well as white babies all over America, but really in the South, it pushed them out of the birthing room. There were requirements put in place for their licensure, and a lot of them could not afford the cost of licensure, so they were not able to legally practice, which then, you know, leads to the witch hunt on midwives of this person's practicing illegally, but we, you know, need to look at the barriers. I mean, now it's a little different, but looking back, back then when this shift was happening, and understanding the barriers that were put in place that made it so that they could not practice, and how that set up this institution that has barriers for people of color to access an education and licensure to be able to practice, which then contributes to the trust that a patient feels with their provider, because you're more likely to trust a provider who looks like you. And part of the reason we need more providers of color is because of this disparity that we're seeing that, has become so severe because of racism, because of this push for some of these interventions and the lack of support in the community. But one of the ways that we can hopefully reduce that is by having more providers of color. It's not just about having someone who looks like you, it's also about the culture you come from, and somebody who understands your culture, and or even just has basic training in cultural competency and is able to speak with an open mind. I think oftentimes when we're talking to someone who comes from a very different culture from our own, even if we're trying not to appear judgmental, some of the questions we ask are unnecessary. They don't need to be asked in order to provide care to somebody, and they just make that person feel. The only example I can relate it to is a circus act of there's something unique and special, and they need to be asked all these questions instead of just provided with the basic care. So there's some harm in the colorblind mindset of oh, I don't see color, because we do need to understand health equity and the barriers that someone's facing just because of the color of their skin in order to support them in the right way. But to a certain extent where we're not really making them feel different or something's wrong with them. So the expectation is not that everyone is going to shift to this model of care and we're going to have this many appointments, and I don't see that happening really ever. But again, equity over equality. So this is a picture I always use. That first image would be equality. It doesn't really seem fair when you look at it though. Equity is giving each person, it's understanding that they have different circumstances and allocating the exact resources and opportunities needed to reach an equal outcome. So with birthing parents, you might see maybe they each have the same opportunity. In a nuclear family, a mother and a father have the same opportunity to return to work postpartum, but it's going to look different for the person who gave birth. It just is, especially if they're nursing, even if they're pumping. As we start to talk more about those different things that are happening postpartum, those are each just added barriers where they're going to need more support. I really like the statement, the saying, "It takes a village." I don't think that we're meant to do everything on our own, especially as parents, but I don't think we're even meant to do everything on our own as people. I think a lot of people learned that lesson during the pandemic. We rely on basic interactions that we have, someone at the grocery store asking you how you are and your neighbor waving at you. And I think it's really important to remember the need for that support in the postpartum period especially, but even throughout, pregnancy. I've heard from a lot of families that they thought that their village was just going to be there when they had a baby and they just fit in with all the moms in the community, and it wasn't the case. They had to build that village, and when you're postpartum and you're healing, we should not be pushing people to go out in the community and make all this stuff happen for themselves. There shouldn't be this big push to just get out there and hit the ground running when you're still bleeding and should be at home resting and healing your body. But I think as providers, being aware of the supports that already exist, and being reasonable in the way that you recommend them. I've seen a lot of hospitals that are really closed off to the idea of handing out different pamphlets and brochures and stuff to people on the labor and delivery floor, but being aware of those community supports that exist and being able to say not just here's one group that you could go to that's a postpartum support group or a play group, but here's 4. Try one. If you don't like it, go home, rest, do what you need to do. But next week, try another one, because, you're not just gonna automatically fit in with everyone when you become a parent. And I think a lot of parents feel discouraged finding support in the community when the first like social support measure they tried didn't feel right to them. But I think there's like this disconnectedness that's kind of happening between all the different providers in a community. And I think New England in a way does it a little better because the communities are smaller. So providers are often more aware of things that are going on. But I was just on a call the other day and I listed off like 3 very well-known support systems in the community, and somebody else jumped on who's a nurse and said, I didn't know any of these things existed. And she was quoting like different programs that exist an hour away. I was like, nobody wants to take their newborn and drive an hour away when they're on like a strict eat, sleep, play, whatever schedule, and probably cry the entire drive. So being aware of things that are local and easy to access. Even, I mean, virtual support groups exist too if someone's struggling to get out of the house. Some of the ways that we could see this in the workplace, you know, it depends on the job, but I've seen people who are able to bring their baby to work in baby wear, especially if they work a job like retail where they're on their feet a lot. That baby's probably just going to snuggle up and sleep. Working in a place where the Pump Act was just passed, so laws have changed. But before, somebody who smoked cigarettes had more rights to accessing a cigarette break than somebody who was pumping milk for their baby. So working in a place, maybe with a daycare close by, I once worked in daycare where somebody worked at a high school across the street, and on her break, she'd walk over and nurse her baby, go back to work. And that schedule sometimes worked and sometimes it didn't, and the baby got a bottle, but she was able to do that when it made sense. And then even just having a comfortable space to pump and kind of normalizing that and increasing access to that is huge. And then the baby-friendly hospital initiative has become kind of a way that some of these gaps can be reduced. There is some, you know, like I grew up in the South and did most of my training in North Carolina attending births, and people had very strong opinions about the breastfeeding policies that hospitals had in place, but there was a really big push to increase education around breastfeeding, which is huge because formula-fed infants are more likely to experience child obesity. Formula, you know, it has its place, and I'm not saying like we should get rid of formula, but babies who are fed formula are more likely to have asthma, allergies, or diarrhea. Diarrhea is the leading cause of infant death worldwide. And one of the most common things that providers hear is from a family who's decided to stop breastfeeding is that they thought about going back to work and it just didn't make sense. Or they didn't have the education around breastfeeding for it to seem possible. Part of the Baby-Friendly Hospital initiative is to train all healthcare staff in skills necessary to implement the policy, which is why I think, you know, I might be saying some things where you're like, this has nothing to do with what I'm going to do in my career field, but it probably will come up. And having that training and education is really important. The likelihood of continuing breastfeeding past 3 months, past a week, past any point in time is drastically increased and more likely to happen if breastfeeding happens within 1 hour. So the golden hour, having skin to skin, a lot of those practices are what's being put in place with the baby-friendly practice. And then, yeah, in the community, having parent support groups, resources for meal trains. Some communities have diaper banks, community baby showers where they're like able to provide families with resources they need. Yeah. That is it. And I know you guys have a quiz, so I'm going to end it there. It was a lot, but I think that there's ways that community members can all kind of come together and realize that we're all working towards the same goal, and that it becomes more possible with more community support involved. Yeah.
Thank you so much.
If you have any questions, my email is, like, you can share it with whoever.